Otherwise, I guess you're also exchanging on a daily basis. So in the So I will on with the last speaker. He's going to talk about the radiation treatment plan for pediatric cancer, clinical view. Dr. George Giakoumettis from Medical Physics Department from Aristotle University of Thessaloniki. We hear you. Hello, my name is George Giakoumettis. I'm a medical physicist. I'm working at AHEPA University Hospital, as you can see, and I belong to the Medical Physics and Digital Innovation Laboratory. First of all, I want to ask, how much time do I have?
15 minutes.
Zero? Okay.
1 hour, we have pushing time zone.
Great. So, of course, physics. Okay. I'm going to show some outline here. I'm going to see what we can learn something about our perspective of medical physics. I want you to understand the difficult how to create a plan. And here we are going to see some statistics that we have already shown. The radiotherapy in pediatric cancer, photon-proton therapy, some history for protons. And I had a systematic review with the help of artificial intelligence, and I will come to show the results. First of all, as you can see here, globally 400,000 children and adults have per year develop cancer. The most common cancer, as you can see, is leukemia, neuroblastomas, Wills tumors, brain cancers, rhabdomyosarcomas, lymphomas, retinoblastoma, osteosarcomas, and Ewing sarcomas. The next two, I want to say that, okay, we have the statistics. We have the 35% of the leukemia. We have the 7% of neuroblastoma. And you can see about the brain cancers here is the 15%, mostly of gliomas and medulloblastomas. Also some other statistics, rhabdomyosarcomas accounts 8%, lymphomas, retinoblastomas, and osteosarcoma. Okay, what I want to say here is that we have to find the treatment effective for the children. This is the importance here. It's very difficult because as for radiotherapy, as you can see here, leukemia is not a primary form of treatment, but it is used only for metastasis. For brain cancers, it's almost for all brain cancers. As you can see here, the radiotherapy is playing a crucial role here. And as you can see, retinoblastoma is radiosensitive. It has indications for external beam radiotherapy, IMRT, or better proton beam therapy. Okay. Here is an article, a paper that talks about the pediatric cancers and the role of the medical physicist. So, what we have here? For photon therapy, many people have already heard, 3D conformal radiation therapy, intensity modulated radiation therapy, volumetric modulated arc therapy, helical tomotherapy, stereotactic, and brachytherapy. So basically, these are our weapons. As you can see here in the stereotactic body, for bone tumors, metastatic and recurrent lesions is under investigation. But also some centers are using brachytherapy, the high dose rate HDR, to treat pediatric sarcomas. Here in Greece, what we have is basically, I don't know where it is. Okay, basically we have the 3D conformal, IMRT, and VMAT. Some centers may use tomotherapy. I'm not sure about that, but basically, the basic weapon is VMAT and 3D conformer. In my department, that we have. Here is a case of brain radiation for a child. It was, I think, 10 years old. We use the VMAT technique, and what I'm showing. Okay, you doctors say that treat the cancer. I have to shoot the cancer. I have to shoot the PTV. It's difficult for a child because I have so many constraints to see here, what I have to accomplish. Also, I have to the PTV to cover the full, the 95% of the dose must cover the 100% of the tumor. And as you can see that here is the VMAT, is the arc, 360 degrees. It's a double arc. That means 1, 2 rounds. And here are the segments. This is the segment that plays the crucial role because it gives me a very good conformity for the tumor. The problem with the VMAT, I have to say, is the low dose buff. So we must be extra careful when it comes for children. The next case I want to show is that we have at our department a pediatric medulloblastoma, which was a re-radiation. It was very difficult, to be honest. Also, there was an extra target over there. And the difficulty was that the child had already taken the radiotherapy dose that it had to take. And we figured out to create a half arc targeting only this one and towards the lenses and the lacrimal gland. The result was very good. After 3 months after the VMAT irradiation, disappeared. So basically what I want to say, photons are also good. Craniospinal radiation. You have already saw the craniospinal radiation. Here is with photon, here is the proton. The problem with photon, we have to use 2 or 3 isocenters. We have the photon traveling through the body. So I have to take care about the toxicity, the deleterious effects. For protons, I don't have. So that was our weapon for photon therapy. For proton therapy, you have already heard about it, is the pencil beam scanning and the intensity modulated proton therapy. So basically, I don't want to speak any further. You have already heard about the pencil beam type yesterday, today. What we have is conformity and flexibility. It's okay, but we have something better. IMPT, it's more complex, highly modulated, but we have a highly conformer. So, a short history. The idea of proton beam therapy is not something that we came up yesterday. It's about 100 years ago, approximately. What I want to show here is that 1954, first patient treated with proton at Berkeley Radiation Laboratory. After that, we are trying to figure out how many proton therapies are in Europe or globally. Nowadays, there are many centers. So I was curious, is it so good to have proton beam therapy? And why we don't have it here in Greece? So I made it a systematic review. The keyword was proton beam therapy and pediatric cancer. My inclusion criteria was English, original studies, the age I wanted under 18 years old, and the last 10 years. The exclusion criteria, adults, mostly. Surprisingly, there were Only 584 articles. What was useful for me? 37. The results. I wanted to find if there is any guideline for proton beam therapy. I didn't know. I'm not an expert. So this paper is from Japanese society that suggests, based on the type of the cancer, if there is any strength or recommendation to use proton beam therapy. As you can see here, medulloblastoma is high, moderate, to be honest. But around the massetercoma is low. Also low, very low is Ewing sarcoma family of tumors. Okay, so protons are useful or no? Here it comes from the United Kingdom program from non-central nervous system group. And what we have? 86% survival rate and 90% local control for the children. As you can see, the most common complication was the cataracts, and it was effective for the control of the disease when we have acceptable toxicities. So, what I want to say, from the evolution of proton radiation therapy based on constraints in pediatric, and there is a meta-analysis about the craniospinal radiation. Here it talks that we have to have more strict constraints about the brainstem, and here I was talking about the toxicity that we can have from the craniospinal radiation with photon. What I want to keep, so here for protons, particles, okay, for photons, a choice. As a physicist, I have to know the back peak. And for photons, that they are depositing the energy entire the path. The precision, I have a high precision with protons, less precision with photons. Side effects, less with protons. Clinical use, pediatric, as you can see, it's very good, it's very useful. That doesn't mean that we cannot do it with photons. The problem here is the cost and the availability. It's very expensive. For us, more affordable is to do with photons. So basically, the message I want to pass is that we want protons in Greece. We would like to use it. We don't have, I don't know, the money. I don't know the problem. But it will help us with the pediatric cancers. Thank you very much. You have already said everything about me.
Thank you again for the beautiful talk. And you gave us all the information from the recent literature. So if there is any question or comment from the audience or from you.
Thank you very much for this overview and for your last words. Before I come to my concluding remarks, I would like to say that you're absolutely right, that there is, especially for pediatrics, the need, but with the evidence, unfortunately, it's somewhat with the effects and side effects of radiotherapy. They only come with a certain latency. We know about the dose-response relationship, we know about the dosimetric advantages, and we know the scenarios where they are definitely of benefit. But until we can show that, until we have the evidence, we will have to wait probably a couple more years. But in my opinion, this emphasizes even more the need to act now. Because if we wait until we have those results, and if we then only start pushing things forwards, we will probably lose another decade or even another generation. In my opinion, and what all the speakers have shown quite nicely, there's a good basis and evidence for proton beam therapy for pediatrics. And now I just switch continuously into my concluding remarks. At this side, thank you very much to all speakers for your nice talks and for this overview. Thank you. All the speakers have elaborated very well the broad spectrum, the incidences, and especially with an emphasis of the balance to treat the tumors as radical as possible, but to keep an eye also on the side effects. And we've seen so many times how much potential proton beam therapy offers in reducing side effects and secondary neoplasms, but also adding benefits to the local control, which is the very first goal of our treatment, because the protocols are changing. We've seen ependymoma, we've seen Ewing sarcoma. The doses that have presented us partly from older protocols that have changed, because we know that dose escalation is necessary to achieve a higher control. And proton therapy is a very good tool to increase the dose while respecting the tolerance dose. And what I also liked is really the interdisciplinarity of this clinical session, because that also reflects our daily work with the neurosurgeon, with the pediatric oncologists, with the radiation oncologists, physicists, biologists. And this is what I love about my profession, because it's very interdisciplinary. And with that, and just 2 minutes late, I would like to end that session, and thank you all. Thanks.
Just 1 more minute, please.
Yeah, here closes the session in this room, but I just wanted to remind you that in the main auditorium, Professor Roberto Orecchia and Arnold Campos are giving a presentation in the framework of the Aristotle Medical Forum in the session of the role of artificial intelligence in radiation therapy. So I encourage you to just step in the main auditorium. Thank you very much.